This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff with the Neurology podcast and Thomas Jefferson University. I'm here with Per Borghammer. Per is a physician researcher at Aarhus University in Denmark, and he's part of a research authorship team that published a recent paper in Nature Neuroscience titled Sympathetic and Parasympathetic Subtypes of Body-First Lewy Body Disease Observed in Postmortem Tissue from Prediagnostic Models. In this study, Per and his colleagues looked at pathological and other postmortem data from a number of patients with Lewy body pathology. In doing so, they identified that among a subset of body-first cases of Lewy body disease patients, there were deeper subsets of patients with predominantly parasympathetic and sympathetic nervous system involvement, respectively. We wanted to bring Per to the podcast to help put these findings in context with what researchers have been learning over the past number of years about biological biomarkers and underpinnings of early and premotor Parkinsonian disorders. Per, welcome to the podcast.
Thank you very much for having me.
This study was grounded in the concept that Lewy body diseases like Parkinson's disease and Lewy body dementia can be sorted into a brain first and a body first subgrouping or subtype. Can you help set the stage a little for us and teach us about what do we already know coming into this paper we're going to talk about with regards to those pathologic subgroupings?
This work is meant to teach us about subtyping in general in order to reach a future of precision medicine, if you will. So about 20 years ago, Heiko Braak, a famous German neuropathologist, proposed a very influential hypothesis where he basically stated, it seems like Lewy body disease starts in one place or very localized and then spreads from there. So a little bit like a cancer analogy, one primary tumor, the rest is metastases. So he proposed back then that it basically mainly starts in the guts and then spreads in a bottom-up fashion. So we have known for some time that idea, although influential as it is, incomplete, if you will. So the brain-body first idea is a more modern development of that hypothesis. Basically, what we propose is that there's two overarching subtypes. Either the very first pathology starts in the gut, spreads via the autonomic system, and then invades the brain from there, reaches the bottom of the brainstem, and then goes up and up. Those sorts of patients typically develop very early autonomic problems like constipation, orthostatic hypertension, and they develop REM sleep behavior disorder before diagnosis, because that comes from the pons, which is below the nigra. So it is reached first in a bottom-up spreading manner. The other group is the brain first, or you could call them mainly nose first. The pathology probably enters via the olfactory bulb, spreads to the limbic system, amygdala, and then directly to the nigra, because those structures are heavily connected. That means these patients, they have a shorter prodromal phase. When they're diagnosed with their Parkinsonism, based on the dopamine system, they have not yet developed autonomic problems or REM sleep behavior disorder. But since the pathology then spreads in a top-down direction, opposite of the body first, they will develop RBD, REM sleep behavior disorder, and autonomic problems after diagnosis. So that's basically the two overarching types.
So to recap what you said, there's the brain first, or perhaps we think of it as a nose first, given the olfactory origination of that spread that then spreads to the limbic system and then to the nigra and then caudally down through the rest of the brainstem. Whereas the body first subtype, we're thinking about initial symptoms perhaps in the gut and then a proximal spread up the autonomic nervous system up into the brain with some RBD preceding the motor onset. Given that between those two pathways of disease progression, let's get into your paper, and at a high level, can you tell us what's the main take-home summary of this paper and what's the new high-impact knowledge that was gained here by what you and your colleagues did?
Yes. So what we found basically is evidence that the body first type, so the type that starts in the periphery, probably mainly in the gut, seems to, in fact, have more than one type, a parasympathetic predominant. So this is a type that probably invades the brain initially via the vagus nerve, reaching the vagus nuclei at the bottom of the brainstem. And then the other body first type is a sympathetic predominant, which spreads mainly via the sympathetic connectome to the celiac ganglion, the sympathetic trunk, and then it reaches organs like the heart from the sympathetic trunk very early. So that's basically the main finding here.
So now we learned about brain versus body. Now we're talking about within that body first subgroup. You and your colleagues are finding evidence that there's another two subgroups in there falling across parasympathetic and sympathetic pathways of degeneration and disease spread. So before we get into that more, can you tell us a little bit about the data set that you and your colleagues used here? This is based on postmortem pathologic data, if I recall correctly. And so what do we know about the data that informed this research and maybe the clinical features of the patients that were used to create this data set we're talking about?
Yes. So the data set we used is a large Japanese postmortem data set collected in Tokyo and Osaka, Japan. And it's a very unique postmortem data set because it's fairly large, 173 cases, all of whom had Lewy pathology. A unique point is that in addition to having full coverage of the various brain regions, they also have a lot of information about Lewy pathology in the peripheral organs, including the sympathetic trunk, the heart, the gut, adrenal gland, and other organs. The fact that they have this coverage of the peripheral organs is quite unique. Only very few data sets in the world actually have that. The second unique point is that the majority of cases actually very early, what we call incidental Lewy body disease. So these are patients that happen to die for other reasons, and they had no symptoms of Lewy body disease, so no Parkinsonism, no dementia, and so on. But they just died with very early preclinical stages of Lewy body disease. So you could say the pathology has not spread very far yet. If you are hunting for where does the pathology actually start and where does it initially spread, you really need to study the earliest cases. Because once a patient has a diagnosis of Parkinson's or dementia with Lewy bodies, the pathology has basically spread almost everywhere. So it's a little difficult to pinpoint where do we think it started when almost every single region is already involved. So that's why these very early cases are so special.
Yeah, I think that's helpful. And obviously for the question you and your colleagues are trying to answer, that makes a ton of sense that these are patients who, one, we have brain pathology data about the extent or the localization of Lewy pathology. But as you said, the other pathological data from outside the brain, in the heart, in the adrenal glands, in the rest of the body gives us a lot of helpful information about where can we find this pathology. And then to take that one step further, it sounds like these are cases that are early in this clinical syndrome and specifically premotor in that clinical syndrome where this pathology is being found incidentally, not as part of a postmortem evaluation of someone with a known Parkinsonian disorder. Let's hear a little bit more detail about how you and your colleagues went about subcategorizing these patients into those specific autonomic groups that you mentioned, the parasympathetic group and the sympathetic group. And it sounds like there's a machine learning algorithm that was really integral into doing this analysis. And can you tell us about that algorithm and what it was trying to look at to parse out these body first groups into these two autonomic subgroups?
We initially did a manual handheld analysis ourselves. That was how we started out before we applied the machine learning algorithm. So in the handheld analysis, we basically divided all of the patients into two groups, quite simply. And what we did is we said, okay, we characterize how much pathology is in the autonomic system. So that's the bottom of the body, if you will, or the nervous system. On the other hand, how much is there in the limbic system and the olfactory bulbs? That's at the very top. Okay, so if you have patients that have more pathology in the top, in the nose and amygdala, whereas they only have a very little at the bottom, then we categorize them as brain first because they have most in the brain. And vice versa, if they had more in the autonomic system and almost nothing upstairs, then we characterize them as body first. So we did a handheld analysis, which basically showed us that there are these subtypes. Okay, so just wanted to make that clear. Then we fed the entire data set to this algorithm, this machine learning algorithm called Sustain. And the point of Sustain, it's been developed specifically to look at data sets like postmortem data sets, which obviously are cross-sectional because it's dead people And so we only have that cross-sectional snapshot of every single person. But what it does is, so it takes all of these data and it sorts them into patients with very minimal pathology, only very little, perhaps only in a single place. And then the next category is 2 places, and the next is 3 places, and more pathology builds up. So basically, it sees all these different profiles of pathology that varies among regions. And then it's trained to guess, if you will, which is the most probable starting point and how does the pathology spread from there. And then what it does is that at the end of the day, it gives you an estimate. This data set, there's only one subtype. They are all the same. Or are there 2 or 3 or 10? Basically, the solution it came up with is that there's a brain first type starting in the olfactory bulb, spreading to the amygdala, then the nigra, and so on. And then in the body first, there's actually 2. Both of them seem to start in the periphery. One of them travels mainly via the vagus, and then quite soon starts to ascend up through the brainstem, whereas the other seems to travel only via the sympathetic connectome to the trunk and then the heart. And all that happens before there's any invasion of the brain. In the Japanese data sets, it's actually quite a large fraction of the earliest cases, maybe like 30% or something like that. They only have pathology in the peripheral nervous system. So it's a peripheral nervous system disease only at that initial stage, before the CNS is invaded. So that's basically what it's trained to do based on, of course, a lot of high-level statistical analysis.
To summarize what you said, manually, you looked at the pathology data and divided the data into those 2 groups we talked about before that are more well-established, the brain and the body, looked at autonomic pathology versus olfactory or limbic pathology, but then using this sustained algorithm, gave it access to that data. And it was from there that these further subtypes start to emerge within the autonomic patients of a sympathetic versus a parasympathetic. Does the algorithm help you within that body first group estimate a percentage? Are we looking at roughly a 50-50 split, or is a sympathetic group a little bit smaller or larger of the sort of division there?
Yeah, so the numbers from this particular data set is overall, there were 51% in the brain first, 49% in body first. So that's 50-50. In the body first category, there were 22% of percentage points were sympathetic and 27 were parasympathetic. So again, approximately a 50-50 spread. Obviously, this would have to be reproduced in at least one other data set for us to know if those numbers hold up.
Okay, so it sounds like we're at least on the data set we have so far, we're cutting groups in half, roughly 50-50, but we need to look at other groups and see if we can replicate that. So you've mentioned some of the organs outside of the brain that are involved pathologically. And so do we have any reason to believe that the clinical manifestations, especially noting that we're talking about often premotor patients here, do we have any reason to believe that the clinical manifestations may be different across these body first subtypes, the parasympathetic versus the sympathetic? And is it possible that looking at those clinical features could help us get to what you had mentioned at the beginning of our conversation about a precision medicine approach? Or am I getting too far ahead of ourselves and it's too premature to get there?
First of all, we believe that disease entity called pure autonomic failure, that of course all neurologists know. So that is very often a Lewy body disease. These patients are characterized by very severe, mainly sympathetic symptoms very early on, and it can actually remain, it seems, a sympathetic disease for many years. They have severe orthostatic hypertension and so on. We believe that the pure autonomic failure patients are mainly a sympathetic predominant body first disease. Okay, so that's one thing. Now, if we take the much more common group of REM sleep behavior disorder, so if you go to a sleep clinic, and some of the clinics will have scores or hundreds of REM sleep behavior patients, and we have a large cohort that we are studying in vivo. So these patients are actually quite heterogeneous. All of them have REM sleep behavior disorder, but maybe only, let's say, 40% actually have orthostatic hypertension in a cross-sectional study. And it's not all of them that have a lot of constipation either, but some of them do. And when we look at MIBG cardiac SPECT scans, so that's a scan that can measures the state of the sympathetic synapses in the heart. We can see that almost all of them are quite sick in the heart, but again, some more than others. Some of them, the heart is completely invisible, and some of them we can still see as some of the heart innervation. I'm guessing that in that group of REM sleep behavior disorder patients in a sleep clinic, that is actually a mix of sympathetic and parasympathetic predominant, where the sympathetic predominant are the ones that have orthostatic hypertension and the more invisible heart, if you will, on the MIBG scan. We're trying to come up with ideas on how to test that now prospectively in patient cohort studies.
Yeah, I think that makes sense. So again, looking at the autonomic body first group, those with more sympathetic pathology, it makes sense that features like orthostatic hypotension would reflect more of sympathetic nervous system pathology. But what you're saying, if we look at other premotor syndromes like patients with REM sleep behavior disorder, we see more of a mix. But if we look at those MIBG scans, we can see there is a chunk of those patients that reflect, again, more sympathetic dysfunction as opposed to parasympathetic dysfunction. Do I have that correct?
Yes.
So now we have potentially 3 groups of Lewy body patients sorted into groups based on how the pathology starts and spreads. We've talked about the brain first group starting in the olfactory system, spreading to the limbic system and then to the nigra. And then we have these 2 body first groups, the parasympathetic group with constipation and vagus nerve spread, as well as the sympathetic group that starts also with sympathetic damage, specifically in the cardiac system. For clinicians who see patients with Parkinson's disease and other Lewy body mediated disorders, we get asked all the time, how did this start in reference to the disease that they have? And so based on what you and your colleagues have learned in doing this work, understanding there's more work to be done, how do you think we can start to refine the answer to that question when we're addressing patients and families who want to know, how did this begin and where did this all come from?
Yeah, so as you said yourself, Jeff, more work certainly needs to be done first before we want to apply this. But again, if our findings and the whole model holds up, it's definitely usable. So for instance, if you have your typical early stage Parkinson's patient, so this is a patient with quite asymmetric Parkinsonism, mainly in one side. You talk to the patient and you'll learn that the patient does not really have any autonomic problems. There's no constipation. There doesn't seem to be any REM sleep behavior disorder. So in fact, it's quite an early benign disease at this state, if you will. So that sort of patient, if he or she asked the question, you would say, this disease that you have probably started in your brain, or it probably entered via the olfactory bulb, potentially because of something you inhaled. Or maybe you had a virus infection in your nose at some point. So that would be the best guess there. On the other hand, the other type of patient where the spouse, it's mostly the spouse that complains about the REM sleep behavior disorder because they get woken in the night by it. So some patients have a spouse that tells that they've been shouting during the night for 5 or 8 years and they only have bowel movements twice a week. And it's been like that for years as well. So in that sort of patient, you would obviously say that this is probably disease that started in your gut many years ago, 15, 20 years ago. And it has taken its time working through the peripheral nervous system to get into the brain. I would say we have more and more evidence to substantiate that is a reasonable way of thinking about the disease.
Yeah, I think that's helpful. And I agree. I think when you can tie in the clinical symptoms or the clinical history that the patient or the spouse is relaying to you and ground that in what research that you and your colleagues are doing and the pathological mechanisms of that spread, then I think that will help educate families and help ground it with them and help it make sense to them. Per, here on the Neurology podcast, we've had a lot of prior episodes and conversations about the growing and emerging use of biomarkers in Parkinson's and related disorders for the purposes of diagnosis. And so the research that we've been talking about here certainly seems to have implications there as well. And so is there anything you would want to add with regards to how we might be diagnosing Parkinsonian disorders now or in the future, how the research that you and your colleagues have done and what we've talked about might inform that diagnosis based on what we know about the spread and even the origination of that original pathology?
There's actually another finding that came out of this work that we did. And if we focus on the brain first group, then we are finding that brain-first patients, they don't seem to develop a lot of peripheral organ pathology until right about the time of their diagnosis. So, meaning that in the prodromal stage, it seems like most of them do not have pathology in the skin or the gut or in any other places. So why is that important? That's very important because there's a lot of work right now to promote and develop biomarkers in plasma and in skin biopsies and so on, gut biopsies. And they work really well in diagnosed patients. And they should, because our study shows that everybody has it in the periphery, in the skin almost, after diagnosis. Furthermore, we also know that they work well in prodromal body first because we have been studying REM sleep behavior patients, and it works there. And it should, because our study shows that they have a lot of peripheral pathology. But to my knowledge, there's not a single study that have looked at prodromal brain-first patients because they're very difficult to find clinically. So I'm just worried about that an assay like a skin biopsy, that it might actually not work very well 5 years before diagnosis in brain-first patients. And that's tremendously important in the future. Once we have a disease-modifying treatment that we can offer the patient, then we want to find them 5-10 years before diagnosis. And this work suggests that it'll actually be tricky to find them, at least based on assaying the peripheral organs.
Yeah, I think that's a really good point. And if I'm hearing you correctly, if we're going to be looking outside the brain to try and make preclinical diagnoses, then the risk we're running is that there is a group of patients in whom the prodromal pathology is happening in the brain itself. And perhaps looking at skin and looking at blood is not going to have the sensitivity or the ability to detect that prodromal Parkinson's. And we need to continue to look at how can we find these olfactory or brain-first patients before that pathology starts to affect the nigra and the dopamine and result in clinical symptoms. Do I hear you correctly?
Yes.
Per, thank you. I've been speaking with Per Borghammer from Aarhus University in Denmark about the paper he published with his colleagues in Nature Neuroscience titled Sympathetic and Parasympathetic Subtypes of Body-First Lewy Body Disease Observed in Postmortem Tissue from Prediagnostic Models. The paper was published in March of 2025 in Nature Neuroscience. Per, thank you again.
Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.